Hello, my name is Peter Minton, and we will be discussing exertional heat illness today. So, the primary types of exertional heat illness will include heat syncope, heat exhaustion, and heat stroke. Each of these are serious and may be life-threatening, but are always 100% avoidable. So, we must now figure out how we can differentiate between the three illnesses. Heat syncope will primarily be associated with a sudden collapse within the first few weeks of training and after a race or workout. Heat exhaustion will typically present with excessive fatigue along with minor CNS changes and dehydration, sweating, dizziness, and more. Heat stroke will typically present with an obvious CNS change along with the similar symptoms shared above. All three of these will include some sort of sweating, dehydration, fatigue, and obviously in a hot environment, although not always in a hot environment. But it's important to know that these three different illnesses can have three very different outcomes. So in our scenario, we have an athlete that after conditioning during the hottest part of the day, they are staggering off the field and you notice that they almost fall over. As you go over to approach them, you ask them how he's doing, and he's noticeably aggressive and agitated for no apparent reason, and you know that that's not his typical mental status. You also note that he is sweating profusely. It's a very hot day, obviously, and he seems to be dehydrated as well. As we assess the athlete, we must immediately remove them from the heat by moving them to a shaded area. We must also note that the athlete shows signs of dizziness, fatigue, dehydration, and abnormal agitation and aggressive behavior towards us. These signs and symptoms point towards a possible heat stroke, but the only way of knowing that is assessing this through a rectal thermistor. Here we have a picture of the rectal thermistor. This is the gold standard in order to record core temperature readings. So, as stated previously, we must assess the athlete's core body temperature using the rectal thermistor. The AT must apply gloves and clean the rectal thermistor with an alcohol swab prior to use. It is also helpful to lubricate the thermistor to reduce friction. The AT will have the patient side lying and covering their posterior with towels, and then inserting the rectal thermistor approximately 4 inches in order to adequately assess the athlete's core body temperature. From then, the EAP must be activated with someone targeted to call EMS while the athlete is cared for by the AT. The athlete will be submerged into cold water up to their neck in a cold water immersion tub that is on site. The thermistor will be left in the athlete as it will continually monitor the core temperature, and the patient must not be transported until core temp is under 102 degrees Fahrenheit. This is possibly the most important thing that you should get out of this lecture, as an athlete that is transported prior to being under 102 has a much more likelihood of sustaining a very bad outcome. This must be treated with the utmost importance, and early cooling and not transporting until cooled are the two most important factors to take in consideration when dealing with exertional heat illness.